And anybody else that wants a new picture, of course.
Slide it out your way or doesn't matter.
Consent agenda item, Jim pointed out that the August 16th minutes were actually the August 19th minutes. Other than that, are there any questions? If not, I would ask for a motion.
I move we approve the consent agenda items with the change to August 19th.
Second. Second, those in favor? Aye. Thank you. Financial report, Cheryl?
Okay. I can't see that at all.
I can't either.
Okay, so maybe I'll just tell you.
Can we turn the lights off completely?
Here.
Can you turn half of them on?
Yeah.
Oh, there you go.
Oh, we could scroll through it.
Maybe a little bit less than that, but that's pretty close.
Yeah.
Oh, that's much better.
Can you, gee, this is just like taking an eye exam.
No, I'm fine.
Can you read that? No, I can't.
No.
This, quick.
1, 2, 2, 3.
Okay. Well, I can't see that very well, so I'm just gonna tell you what's on there, okay? We're looking at July. July's the first month of the new year. So this is July of 15 and this is July of 14. So year-to-date is just 1 month. So really, the only thing I noticed, it is pretty average, month over month, it's pretty comparable. Swing beds were down, and inpatient was down year over year. Lab and radiology were a little bit below our last year average. So really what I did was I looked at this and compared it to the average for all of last year, just to see where we're at. Those were down a little bit. The one crazy number is home health hospice. They are just crazy busy, and it's feast or famine, and there's real no predictor of where that's gonna be. So
The
they are
lab
very.
exams, is the variance really 1,287?
Pardon me? Lab exams, ooh,
No, it's,
Wow,
it's not.
It's not, okay.
okay, is that
It
where my
should be
error
like,
is? Where are you looking?
2,458 less 2,516, it's not 1,287.
The last number.
Hey, I'm sorry, I feel totally blind. Where?
Up,
Right above, right
stop. Lab exams.
This number,
Yeah.
oh, okay. Right on, I will fix that number. I don't know why I got so happy, but I'll fix it. Thank you.
Had to find something.
That's all right. Okay,
It was a decimal point, it's 128, not 1,287.
which is kind of weird, but okay.
Sounds more reasonable.
Yes, absolutely. Lab did not have a abysmal month. It was just a little bit slower than the average, not a lot. All right, so our, we had good revenue this month at 2.2 million, which is just a little bit above our average of last year, which is 2.182 million. This is gonna be an interesting and different year for us to analyze because long-term care is not included in that revenue. But in July, we did start billing for the Hussey Gallagher Clinic. So that revenue, that's really quite a bit of revenue. So that's gonna push us up, even though we're losing the long-term care revenue out of this pot. All righty. Okay, so this is our days in AR. I changed this graph a little bit so you can see this is our days in AR right there. We are at 76, it's up from last month. Brian was telling me that what did you tell me?
We signed a contract with United Healthcare,
Oh, right.
and they partially loaded our contract so that they haven't been processing our professional fees, and outpatient clinic visits. And they'll be processed this month. So we have quite a bit of AR from United.
And we have some glitches just with taking on the clinic billing. I mean, not surprisingly, it's a whole new deal for all of them in that office, working with our business office, so there's a lot of little kinks to work out, things that were unexpected or whatever, but everyone's working together really well and working them out, but not surprisingly, it probably will slow us down just a tad for a month or two while we figure it all out. Their billing, and clinic billing. Okay. The next one is days cash on hand, and our days cash on hand is right there. It's at 163. Our average last year was 170, so it's down just a touch, but it's really still in a very good place. And this is our P&L for the month. So, like we discussed, it does not include Lakeview Gardens, but it does include the 2 clinics. So our revenue was about 93,000 less than we budgeted. And we sure didn't, our surgeon didn't really start working until August, so there's not very much. And I don't think Dr. Bradford is here at all in July. So we were a little slow on that surgical revenue. Our salaries are below budget. We're not doing all the things that, we had, that we've got planned for the year yet. The benefit number is a little bit high, but I think that's just gonna be an anomaly for this month because the doctors did want us to, normally when you start as a new employee, you accrue your PTO slowly over time, but they wanted theirs to show up right now. So we went ahead and accrued several weeks of PTO for the physicians so that they could take a day off right now and it would get paid, which is totally appropriate, but that was a little bit of hit on our benefits right there.
That'll amortize out over the next few months.
Well, no, I mean, basically, it's like a richer benefit because you're a doctor. So instead of having to earn it over time, you get it right now. So,
The difference is we didn't budget for it, because when we were preparing the budget, we were planning in a different way, we just processed it.
Gotcha.
That's the only reason.
they'll continue to accrue, right?
Well.
I mean, they started out with a chunk and then they'll accrue some over time.
Yeah, but once they meet, I don't know how much we front-end loaded it, but once they meet it, then the accrual continues to what they were
Yeah.
allowed in the contract.
Okay.
So we didn't budget for that, that's true. So, but anyway, so I think we're over by 5,000, but I don't think that's gonna be the case next month because of that. All right. So, in total, our expenses were 147,000 under budget. So our gain or loss for the month was 91,000, we budgeted 143. On a net basis, we had a net profit of 58,000, we budgeted 8,000, so we're about 50,000 ahead of where we expected we would be.
Yeah, it's just a 1-month budget. I don't
It's just-
expect to see it really gel out in 3 or 4 months.
Right, I totally agree.
That's with the clinic and without the gardens.
Yes.
Okay.
And it, we really weren't very sure what to budget for the clinic, so it's gonna be a learning experience this year. Any other questions?
Given all the changes that we've had from last year to this year, I think we have to admit that Cheryl's budgeting process has gone along pretty well, and we'll see that.
We hope we're gonna see that, you're right, 1 month doesn't really, but hopefully it will. So our current month is right here. This is the prior month, this is the prior year, last year at this time. Really no significant changes. Our AR is up. I would expect our AR is going to go up with the new clinic. Billing for those 2 clinics, I would think is gonna be more than our long-term care. There's gonna be a lot more bills, and it will probably take a little bit longer to collect on them than we do on that long-term care. Otherwise, there really was no changes.
You've got the long-term care software now.
No, but I was gonna talk about that. I mean, we have talked about it. We've agreed to buy it. In fact, I think we've signed a contract. I don't know that we've got a schedule for loading it yet. We did go ahead and buy the general ledger package with it because, the way it's working now, their billing, like Lakeview Gardens billing is embedded in Lake Health District's AR. It's all being done by the same software. So trying to separate those out is extremely time consuming. So I'm very excited that when we get that new package, we'll be able to do all the billing out of that package, all of the APAR, so it will be completely separate from an accounting standpoint, which will make things a lot easier for me.
The software is called Point Click, and our kickoff meeting is September 8th. So it'll be next week, and that'll talk about who all the people, and then we'll go through the process of aligning that. One of the things that we wanted to hold off with is our new IT manager starts on the 14th. So we wanted to make sure that we had our IT manager here so we didn't have too many start-stop issues with implementing the software. That's,
It shouldn't be as complicated as a lot of other software we load because there doesn't need to be a lot of interfaces. So it's, it just is a fairly simple medical record, but you don't really have to build an interface with the lab and radiology and physical therapy because they can be treated as they're, an outside service for the residents of long-term care. So it's not like in a clinic where you want the doctor's gonna be looking at all those records all the time. So it should be a lot easier to unroll than eClinical has been, or other things, or T-Systems. So hopefully it'll be, knock on wood, short and sweet, simple. Okay, so, not really worth on it. Should work. Okay. Yeah, this one's small, I'm sorry. I might simplify it. It was in the package that I sent to everybody. We really don't have a year ago to compare because we weren't doing this a year ago. We still are working with our managers to make sure that we're allocated, these numbers down here that we're allocating, that we're doing a good job of allocating costs, that we're being fair and accurate, and that as we've discussed it with the managers as these last few months have gone by, we've talked about what's working and what's not, and what, making sure everyone understands how this is supposed to work, and so we've made some adjustments, and we continue to make adjustments, but we're definitely, I think at the peak of our learning curve, so I think it's gonna be a lot easier for everybody as these next months go by to keep track of Lakeview Garden expenses. So that makes me happy, and then hopefully it'll kind of settle and not be as up and down as it's been. But altogether, the census was up again in Lakeview Gardens a little bit, so the net profit for the month was 18,000. So that was kind of where we expect them to be.
Woo-hoo.
Yep. Their balance sheet, their AR is all in Lake Health, and their AP is kind of in Lake Health too. So as soon as we get new software, yeah, it'll be, because I can't really figure out like what is days in AR in Lakeview Gardens right now. I can't really tell you that because it's embedded in the other one. So that's okay. This is just going to be a very simple report. I mean, even after we have our own software, it still is going to be very simple. They don't have, they don't have assets. They don't have long-term debt. They just have what they owe the hospital for operating expenses and what they're going to owe their own vendors. And a very simple AR, because you really only have 16 to 20 people a month that you're billing for. Okay, so then going on to Goose Lake Medical Services, their revenue was right here, so quite a bit below last year, but above the year before that. That number was about 55,000. So they are kind of right in the thick of, we've just installed the eClinical Works. We did have a lot of challenges, a lot of issues and problems. I think we worked through many of them, but we still had decent revenue, so that's good. We are definitely experiencing an increase in our days in AR and our receivable balance as we learn how to bill out of eClinical Works. eClinical Works has been very helpful and very available whenever we call them. But we still have everyone, both in medical records and billing, learning how to do it. We also had more glitches with Medicaid, it was Medicaid, right?
Change in ownership.
Yeah, the change of ownership, something got hung up at Medicaid, and so that billing was all hung up. But it's-
Medi-Cal?
Well, Medi-Cal.
Yeah, Medi-Cal, September 1st, we released claims. So we've been holding claims for quite some time. They finally approved us.
Yeah. So that'll work out though. So then, for them, they had a loss of $2,700 for the month. So, I mean, we've got it, our loss is very minimal. Roseanne will be, she had made an announcement and plans to move up here when Bill Elrick was supposed to be here. He has decided he's not going to come. Yeah, unfortunately, I'm not sure what happened. Something happened with, I think, selling his business or what. He wasn't extremely forthcoming, but he did call and tell us that he's not coming. So Roseanne was really all set to be up here. We certainly need her up here. She'd announced to all of the patients that she was coming. So she is going to be moving up here. So we need to kind of redouble our efforts for looking for an FFP for Goose Lake Medical. I don't think that her portion of the income is huge. She has reduced her hours over the last few months, so she hasn't been there as much as she was. So revenue will go down, and I'm not sure how much it's gonna go down, but at the same time, I won't be paying an MA or her wages out here either, so. Anyway, that was very disappointing news. Because he seemed like he was a perfect fit and was very excited about coming, so anyway.
Can you hire locums or whatever you call them?
Yes.
We're
Yes.
in the process of trying to find one.
We've had a couple that looked promising. Sometimes you have to be very careful what you get. So we've been pretty selective, trying to find the right fit. We may move a little quicker now.
Yes,
disappointing.
it is, it's very disappointing, but sometimes the wrong person is a lot more work than no person, you know?
It just seems like we just had one thing
Challenge after
the
another.
other, though. It's like,
Yeah,
it's why, you know? That's,
it's a difficult place.
is there something we don't know? Is,
Well, Alturas is a very challenging place to try to hire people. It is very hard to find even good office staff. I'm not sure why that is. But I'll tell you, they're not all down the road working for Modoc Medical. I mean, they have just as much trouble as we do, and just as much, if maybe not more.
Are we competitive salary-wise? Is that? the
We
issue?
are, well, and we're competitive benefit-wise now too, so we actually probably have better benefits. I really don't know that for sure, but we have good benefits.
Just as a side, I talked to Brenda Clement last weekend, and her husband actually goes to Alturas from Klamath Falls because of Barbara Gilbertson.
Really?
Because of what, Chuck?
Dr. Gilbertson?
Dr.
Oh,
Gilbertson,
I didn't realize
because
that.
she's a pain specialist. Very good, apparently.
Yeah, she has a strong, and Dr. Stevens has a very strong following. But it's just trying to get a good FMP down there has been a challenge. So, anyway, the balance sheet, their AR is up a bit. Otherwise, really no significant differences. Questions on that? Okay.
You can see better.
I see the spots right now.
Have we got anything for medical staff privilege?
We do. Unfortunately, Dr. Graham could not be here this evening due to some commitments he has. We have, at the last medical staff meeting, we have a resignation from Dr. Mayland, Dr. Edward Poon with teleradiology, and Mallory Larkin, PA urology. Dr. Mayland is the physician that has been here coming from Klamath Falls. And he and his wife are taking a year off to go to Australia. So.
They're using that as an excuse.
Good commute.
This is what he's.
Pay a mileage.
I didn't want to pay my.
Good choice.
So, also we have a change. Dr. Spencer Clark has asked to have his privileges changed from active to courtesy staff. Those were accepted. These were all accepted by the medical staff, and their recommendation is that you approve these changes.
Also moved.
I'll second.
Moved and seconded, those in favor?
Aye.
Aye, thank you. Nursing report, I don't see Teresa.
Teresa's not here tonight, unfortunately, given the events outside of the hospital. Everybody's gone at the fair doing something. Sorry. But she said that things are continuing to move forward, and they've been struggling with strong census and a shortage of staff. So that continues to be a problem, actually not just for the acute, but also for long-term care. That's staffing issues. If you keep in mind that with September being the time that school starts, we have, I believe, 3 of our CNAs are in RN programs, or LPNs in RN programs. And that takes away from staff that are able to work. And there's been some other issues, just change in where people are working. So we're struggling with that. And our censuses continue to stay fairly robust.
Geothermal report, Charlie.
I sent out to all of you a report that Daryl prepared for us. And let me give you some background on that. In 2005, 2007, the board commissioned a engineering firm to look at the air or the heating and cooling for the physician offices, phases 1, 2, and 3. So when we talk about the medical office buildings, phase 1 is where our walk-in clinic is, where the specialty clinic is. Phase 2 is where Drs. Gallagher and Hussey have. And phase 3 is where Dr. Graham's office is. Everybody comfortable with that description? And it was called the phases because they were built in phases. I think the original one was in 1982 or so, if memory serves me correctly. In 2005, while we were looking at the construction needs for the facility, the engineering firm said we need to replace the heating and cooling equipment kind of overlooked while we were building the hospital, but we still have to replace the equipment. And if you recall, last May, we had 4 of the units go out, and we had to replace them. Fortunately, because they're significantly past their life expectancy, finding replacement equipment is pretty challenging. So we engaged Anderson Engineering to look at what it would cost to consider moving the geothermal from the hospital to the clinics. And that's the report that I sent out to you. We also asked a couple of contractors, local contractors, what it would cost to simply replace the heating and air conditioning equipment. So the fans and the heat pumps, not changing the ducting, not changing that. And based on that, the studies came back significantly less than geothermal. So in the ballpark, we had estimated $180,000, as Darrell had said in his letter, came out about $20,000, $30,000 less than that. So, based on that, as Darrell reminded me, when a project like this is going to be over $50,000, we need to do a public bid. So I talked to Pinnacle Architecture to see if they could draft up a bid process, submit it to whoever wants to bid on this, and to get the project done. And I hope to have that made available pretty quickly so we can, yes, sir.
I know that we've been talking also about covering the entry area between the clinics,
Right.
and that might be a future consideration to kind of
Right.
meld that in.
So if we were to, the space between the 3 phases, that courtyard, if you will, if we were to put a roof over it, about a year ago, I'd asked CTA, the architectural firm, what they thought it would cost to do that. And they said, Tom Callan, the architect, then said, roughly $300 a square foot was what he would estimate. So for given that space, and it's roughly 100 by 150 feet, so about 12,000 square feet, that would be about $3 million, give or take. Because it may not actually be the full $300 a square foot, because you wouldn't have to put in all of the infrastructure in terms of heating and cooling. The bigger parts are of it. So it may well be that it made sense to put in geothermal. What Darrell has said is that our current capacity of the amount of heat that we can extract from water out of the well, we could handle the 3 phases, the long-term care cottages, and an additional space. So part of that, so it might make more sense to put in geothermal, even though the cost is at least $100,000 more in the short term. But then once you have it, you don't pay for the heating, you essentially pay for the cooling and fans and electrical.
We don't pay for the heat because we already are.
That's correct.
There's no incremental cost.
So when we try to do a return on investment, it's hard to measure exactly how much we're actually going to save, because we're not paying just for the heat, we are paying for the cooling. We are paying for the electricity on the fans and pumps and that kind of thing. We're trying to come up with the best estimate. But clearly, it is cheaper in a 10-year time period to have just replacement equipment. It's much more efficient. It would change the phases. Used to be, if you had 3 phases for air handlers, that was more efficient. They've gotten to where they're now variable speed pumps, which means they can run a single phase, much more efficient. As the contractor described it, if you have a regular car and you just put the gas and then let off and you drive to Bend or Clement, you'll go up to 55 and then down to nothing, and up to 55 and down. If you put it on cruise control, it's constantly varying the speed, but you have it's far more efficient, so you get much better gas mileage. Same thing holds true with these systems. So, I had hoped we could get this done before cold weather really sets in. If the contractors had estimated we could do that. But we're gonna put this out to bid properly. And I'm looking to try and get that done in the next couple of weeks.
How long do you have to give them to process it in?
2 weeks.
2 weeks.
So when I talked to Mark Rossi, that's who I'm thinking we would go with as a independent art group to manage the bid process. And because Darrell does have, he's made this report, but he's also strongly recommending the geothermal process. I didn't want to have any bias for anyone when they're submitting their proposals. And I thought it would make sense to let the architectural firm that doesn't have a dog in the fight at all to manage that process. So,
And I think what Don's saying, put the piping in your bid, is big enough to take the future load.
and we were able to talk, Justin Westcott and I were able to talk with the engineer that helped Darrell yesterday, Brian, I forget his last name, he was here. And so talked about capacity, and I'll be sizing it correctly to accommodate, should we expand that space. I mean, that's really what we were trying to figure out.
So Charlie, are we having a bid is the bid going to be geothermal or both, or both? I mean, are they gonna bid both options?
We're gonna give them the option to bid on geothermal
Okay,
or
just a
regular
replacement.
air handling systems,
Okay.
replacement of systems.
Okay,
So that what we get, because what Darrell did is estimated his costs.
I see that.
And he used a plumbing contractor to do a rough estimate.
Mhm.
He thinks his estimates are good, but if we get a hard bid and they say that's what it's gonna be, and we hold them to that, then we know where we're at, rather than an estimate. It's hard bids.
Sounds good.
And I hope to be able to get that better. I was hoping to have more definitive answers for you today, and that's why I sent this out in advance, because there's a lot of information here. But, and I worry that we're gonna have another system go down. We had that problem when we were interviewing the construction company. How it got so hot. These systems are really on their last legs. We need to be progressive about this.
Well, you need the board to meet to review bids, let us know.
Okay, okay.
And you're really certain that the geothermal that we're getting today can serve all of phases 1, 2, and 3 plus Lakeview Gardens?
I'm using Darrell and Brian's estimates. I don't know how otherwise to judge it. They're experts on this, and so I have to assume that they know what they're talking about. So I guess we could ask another
There's
company.
another well north of
I
town.
know.
Keep it up, though.
Do we have any questions about, is this approach okay with everyone?
Yes.
Yes, sir.
Yeah.
Judy, are you sure?
Oh, yes, it's okay with me. This whole geothermal thing is just, I don't know. It just seems like we haven't saved the money that we thought we were gonna save.
I think
I'm
the
certainly not a professional either. I don't know anything about it either, from the standpoint of, will we have enough heat to add on all of this? At no extra cost. I guess we wait and see, but.
What they're saying is the well has been fairly stable in terms of its temperature. They've been able to pump, and they have not come anywhere near to the capacity that they would need. That the piping is adequate, that the system can accommodate.
Have we had any system issues within the hospital recently with either heating or cooling?
We've had some issues. We had to replace what's called a Jace, which is
That's
one
what
of,
this is, isn't it? Just like is this Jace replacement is?
Yes.
Okay.
That was, and keep in mind, this is now almost 5-year-old equipment that we're dealing with, and it's processing lots and lots of stuff. And we had to send it up to Washington to get it fixed, because that's where it was manufactured.
What is?
The JAST is one of the components that regulates, or is part of the computer system that, as demand for heat or cooling is asked for, it helps monitor and regulate how much we send out, whether it's hot water, cold water, to the processing system, and then you have fans blowing air on that.
Control.
It's a control, yes. And that's part of this process. One of the things we talked about with one of the vendors about filtering systems, and some of the newer equipment has different kinds of, we change our filters a lot. So we look at how, once you install it, changing filters is a much bigger cost over time. So you don't just look at the initial investment of the equipment to process heat and air. But now that you're running a lot of air, filters, and we have all this dust, well, for our main cooling system and heating system, because it is such an exposed space, we change filters a lot. It's not heat, it's filters that impact that. So they're sophisticated systems. And apparently we, according to the reports, we have adequate heat.
We have had what?
We have adequate heat in the well, and there hasn't been any indication that it's been denigrated or that it is even come close to meeting its capacity.
Okay, so arbitrary question, maybe no one here can answer that. And if it doesn't,
We have the backup systems, but they don't have the cost efficiency of the heat pumps.
We have electric and
And
propane.
propane.
We have electric, propane, and diesel.
And diesel,
So one of the challenges that we have been facing is, before we had geothermal, we were using both propane, not so much diesel, that's mostly for the backup system, but propane and electric. We were trying to see which one was more efficient for us and which one cost less. Well, the price of propane dropped precipitously. So at what point in time does it actually, even though we made a huge investment in geothermal, with the price of propane being so low, it's almost cheaper if you hadn't made the investment in geothermal to consider that. But propane can change. We have to think of it as, we've got the geothermal system as a 40-year investment.
you know, Charlie, that brings up another question while we're on the topic, and maybe this is appropriate. Did we ever, where are we with that propane contract that we were talking about earlier between Fuel Commander now, I guess, and AmeriGas, what was the?
AmeriGas and Stop, and both have given us letters indicating their interest in negotiating. One of the challenges has been, since Stop owns the tank, we would have to have Stop remove their tank if we were to change to AmeriGas. So we're investigating, we've asked them to give us a proposal based on whether we bought the tank, whether they buy the tank, or they supply the tank, and so that we get the best price of fuel. And we are still trying to resolve that. No, we'll just negotiate the best price.
If we hang back long enough, they'll have natural gas up here for Red Rock.
That's the other component, for sure. It
So,
really is.
so one of the challenges that we face is, if that were to happen in the next 12 months, even 2 years, then it may not make sense for us to buy a tank, but to continue with rental arrangement.
Right.
I mean, there's a variety of factors that play into what makes most sense for the district. And we are trying to find the best deal. And frankly, the cost of propane is at one of its lowest levels in a long time. So we are in the position to negotiate a good price. but we frankly haven't used a lot of propane.
Yeah, I know.
So when we first started in the new building, we were using a lot of propane. And Stott put in a big tank. We don't use a lot of propane. And so we frankly haven't bought any fuel in, what, 8, 10 months?
Any propane?
Any propane at all. All we're using the propane for right now is for heating the dryers in our laundry. So we don't use it a great deal.
So you're not close yet to signing any sort of an agreement with either or?
We're trying to make sure that we have thought through all of the options. Each have expressed a great deal of interest in negotiating. And we're anxious to come to a deal, but we want to make sure we protect the interest of the district, but at the same time, use our local vendors. That's what we're trying to do. So, the way I would treat this is we would negotiate and not make it into a public forum. But we will try to get the best deal for the district and fairest to our local vendors. Does that answer your question?
That does, thank you.
Employee recognition.
You know, every month I love to be able to talk about our employees, and we have someone that, once again, is an absolutely great asset. This is a person that is always willing to help in any way possible, has been here for over 35 years, and is very accurate in her work. She's very dependable, always willing to volunteer on projects that are needed and accepts change with a very positive attitude. This person is Angie Warburg, in purchasing. We're very pleased about Angie.
Thank you, Charlie. District bylaws and board governance review. I'm sure you all read through it thoroughly.
No, I didn't.
Does anybody have any questions or comments or wish to see any changes?
I think I have some.
All right.
Where do you want me to start? I don't have a lot, but I just, on the governance, on the CEO succession,
Mm-hmm.
do we have that defined, don't we?
I have a copy of it.
Okay.
That Charlie has given me about a year ago. I don't know if it needs updating, Charlie, in your mind?
Hasn't changed.
Okay. Executive succession plan.
Okay, perfect.
That will change when we bring on a COO. But we still haven't, we keep working on trying not to get top heavy, but at the same time, as we keep growing our business, we'll have to keep that.
And we're still looking at a clinic manager position?
Absolutely. Absolutely.
So then we determine whether or not we need a COO.
That's correct. And what we're calling this is not a clinic manager, but a clinics manager, responsible for all the clinics.
Sure.
And we have managers in each of the clinics. Actually, we have managers in 2 of the clinics, and we're looking for a manager for the clinic in Alturas for a more full-time position. But this would be a person responsible for all the clinics. We're stretching everybody's time. Brian, Cheryl, it's just very time consuming. And there's a lot happening as we keep expanding in that area.
Other questions, Judy?
Uh-huh. That's all I had on the policy.
Okay.
But on the health district bylaws, I just had 2 suggestions. And on the one on special committees where we meet with the medical staff quarterly, our bylaws indicate that a report is to be made to respective membership.
I noticed that.
And I know that I have missed some of those med staff meetings and would like to have a report. If any of us miss those, I think it would be really nice,
It's minutes, basically.
yes,
We
to have a
minutes.
report.
Yeah, and if you would just automatically send those to
Send
the
those
board.
out. Okay.
That would be great.
Right, I agree. I'm gonna miss the next one, by the way, it's next week, I believe.
Yes.
Anybody else gonna be there?
I will.
You'll miss it.
And I'm gonna miss it too.
And I might miss it also. I mean,
Gerald, it's up to you.
Hey, it's in good hands.
Oh, that's what we're worried about.
Anything else?
And just one last question, Charlie may know this answer, and I should probably have looked this up, but I didn't. In the medical staff bylaws, does it say anything in there, Charlie, about physicians being board certified?
No.
Okay, so that is absent. Board certification is absent in their bylaws.
It is, we looked it up.
It is?
It is absent, it is not
It is
there, there's no
absent.
requirement
It is
for that in
absent,
the
okay,
bylaws.
all right. That was my question.
Those are on the website, but you have to have a password. And Jen can get you squared away on that.
I can get you the password for that, yes.
Any other questions? Thank you for
Thank you.
doing that next time. And it's just a good thing to kind of go over. Next board meeting, by the way, our regular board meeting is the 8th, or the 1st, and we'll move it to the 8th of October. Because the 1st is a little tough for everybody. I just lost my agenda, I don't know what I did with it.
Well, I adjourn the meeting.
Charlie doesn't
At
get
7:30, you've got 2 minutes.
CEO report.
First thing, I'm glad we're changing to the October 8th. That really helps us think. Getting the month-end close and financials is we stretch to go as fast as we can. That helps us a lot. We're preparing for a lot of things right now, a lot of events. ICD-10. ICD-10 is the change that occurs from ICD-9 coding. ICD-10, this has been something that goes into effect October 1st. The rest of the world is operating on ICD-10. Actually, many more on ICD-12, so we're quite a bit behind. But it's an enormous change in the number of codes. I think we go from 60+ thousand to 350,000 codes. And so the requirements for physicians is going to be that much more. Our staff has been training. We are confident that CPSI will be able to send our claims to all of the vendors, Medicare, Medicaid, and all the insurance companies. We've been testing this. Software companies have been testing it. So we think we will be ready.
We've tested with the payers also.
And we've tested with payers. So, I mean, there was some talk that Medicare might change the date, but 4 months ago, they said, no, we're going to stand by this. So that was a good thing, because they kicked the can down the road a whole lot of times. T-System, we started this discussion about a year ago. We were going to implement in the February it was, I believe. We decided to hold off with that, given the challenges of changing systems.
What's a T-System?
T-System is the software that we have acquired that will work specifically in the emergency room. It is a software that is used in a great number of emergency rooms across the country. We're a little unique in that many hospitals have full-time emergency room doctors. That's all they do. So when they use the software, they can become very familiar. It is widely liked. In fact, it's one of the software programs of all that are disliked, and most are disliked. It's one of the few that is reasonably well accepted. But because our doctors that are covering our emergency room are not full-time in the emergency room, they split their time between the clinic as well as the emergency room. It isn't clear if it will work perfectly for them. We hope it will. We've sent Lisa Cahill to training on it. We've sent our team to be ready to deal with it. Our go-live date is September 22. So hopefully that will work well. And we'll have some bugs, I'm sure. It will help us as we continue to work on meeting our meaningful use. Meaningful use is one of the Affordable Care Act features that was established in 2010, 9 or 10.
10.
And this is where $50 billion of monies were given to hospitals in the United States to buy electronic records. We got well over $1 million to install our system. But the requirement is once you buy it, you have to prove you're using it. And so you have to meet the meaningful use requirements. And we met it in the very first year, and then we did not meet it in the second year. But the original plan was there would be meaningful use stage 1, stage 2, and up to stage 7, and it would change every year. Well, it's very difficult to meet 1, and it gets difficult 2 and 3. So not all of the country has even met meaningful use stage 1. We will be attesting, that's the term that's used to prove that we will be meeting the criteria. For this year, it was supposed to be meaningful use stage 2 of the requirements. Initially, we only had 90 days to do it last year, and this year would be the full 12 months. We just missed, we were just a little bit below last year. We've done a lot of things to try and improve how well it works. Our biggest problem, and we're not the only ones, is the part where the physicians are entering it electronically. So we think we have done some things that will help make it easier for the physicians, doing a lot of things to help make that better. And Medicare said for this year, it needs to be 3 months. And the only requirement is 3 consecutive months. And they made it for the full calendar year, not the government's fiscal year. So our goal is to, our plan is that we're testing it in September this month. And if we do well in September, and it appears that we're meeting all of the criteria but 1, and the T system is going to help us meet that other criteria. If we do, we will be testing for September, October, and November. But we will also have the month of December if we don't meet it. So we're taking this very seriously because we want to meet that. Because when we do, then we can apply to Medicare for additional monies. So.
Are those amounts declining as we go?
Yes. There's monies that is available for the clinics. There's monies available for the hospitals. The clinics, we are not quite ready yet, but with the clinical, if we can get them to use the system well enough, then we might be able to attest. But you have to be using, and that means the doctors can't dictate as much. They have to enter and click. What doctors don't want to be is receptionists, as they say, or just mouse clickers. They don't want to do that. They're expensive, knowledgeable people. And having them do things that a clerk would do is not only demeaning to them, but it's taking away from them seeing patients. Keep working and trying to find ways to make it easier for them. But we still have that meaningful use target we have to strive for. And that's what we're doing. One of the things that Teresa was going to tell you about that we're, again, doing to try and improve our documentation is we have been working on our mobile care stations, or as some people call them, cows. That's the computer on wheels. We don't like to call them cows because, you know, it's got some negative connotations.
Nothing wrong with that.
I understand that, but
That's right.
anyhow, when we got the CPSI system in 2011, we have the same mobile care stations from that time. We've changed out computers, we've tried a lot of different things. So we went through and have been doing a rather rigorous trial of a different kind of station. It's more heavy, it has a much faster computer, it's a touch screen. It also has compartments where we can put medication, so that when the nurses are going to pass medicine to the patients, they don't go to the med room, go to the patient room, go back. So sometimes they put medicines in their pockets and they do things so they don't have to walk around. We think by the end of next week, the nurses will have all voted on which systems, and we will be upgrading our mobile care stations. The difference in cost, we paid about $2,000–3,000 for the 8 per mobile care station that we had. These now will be about $6,000 per cart. But much better technology, much faster computers. We will not be buying all 8 or replacing all 8. Looks like we may replace only 2. So I think that will help our documentation. And important about documentation, keep in mind, that's patient safety. We're not giving the wrong medicine to the wrong person. And that's our most important goal. Brian, Lisa, Pike, and Cheryl will be going to a rural health clinic and critical access hospital training program in Reno in a couple of weeks to help make sure that they're staying on top of all the rules and regulations. We changed our auditors for the rural health clinic in Alturas, and Moss Adams is now doing that. They're more expensive, but they've got some very good suggestions that they want to give to us on operational things as well as financial, how they report it. So we want to keep on top of these changes as they occur. We entered into an agreement with a company called Community Infusion Therapy. Brian found this organization at one of the conferences he went to. We do a fair amount of infusion therapy right now, but this company has some experience working in rural settings where they're able to help the patients much more than we have. They're more on top of the co-pays. They work with the vendors on, because the medication is often very expensive and not everybody has all the insurance, or if they have insurance, they may have large out-of-pocket components. The companies that are making the drugs have benefits, financial benefits that they provide to the members. We think this could not only improve the service we do, but will have a significant impact financially on us being able to treat more patients and do it more cost effectively. So we have a kickoff meeting next week also, and it looks like they'll be up and running in 45 days, 30 to 45 days. So that's kind of exciting change. In order to become a rural health clinic, we have to submit an application, have it approved by Department of Health, DHS, Department of Health and Human Services. When they came out in their, as part of the state survey, the second week of July, we had submitted our application. It now looks like we've been waiting for their surprise visit for their survey. It should occur before the middle of October, I believe it is what they said.
So they just said between, July and October.
So it could be tomorrow for all I doubt it'll be on Monday, but but it could be any day. So hopefully, and we think we are prepared. What is important about that is they'll be treating both the, we're now calling it the Lake Health Clinic East and West. West being where Drs. Gallagher and Hussey are, East being where the other clinic has been. They'll evaluate it as one clinic. And that was one of the big issues, naming, how do we handle billing and all the issues related to that. once we get through that survey, then we'll be able to move further on with that. 2 meetings ago, we talked
So,
about.
excuse me, can I ask you one question about
Yes.
that visit, just because we're on the topic? Should we not meet the standards, the criteria on their visit? Is it the sort of a thing where they tell you what you need to do and a timeline to get those things finished, and then they come back? And then can you then be recertified, if that's the right term?
My understanding is the state will only do it once. If we don't pass, then we have to hire a firm to come in and do that, an independent firm.
A firm that comes in to prepare us and get us up, or to review?
Comes and do the review. We had, for our rural health clinic in Alturas, when we bought it from Dr. Stevens, he'd been in business for 16 years, if I remember, and he had been surveyed once. They're supposed to survey every 2 to 3 years. It had never been surveyed until we did the transfer of ownership from Stevens to Gilbertson. Bingo, they came in and surveyed us, but we were prepared from when we bought it. We've been updating all the policies, we had all the stuff in order, and we did very well.
No deficiencies.
No deficiencies. So that worked out well. So we've taken that knowledge, we've applied it to our facilities as they are now. We've also had the physical evaluation, and we're making all the corrections that they've asked. So we think we will be prepared. But we've tried to do it because they surveyed us in the second week of July. For all we knew, it could have been the third week of July they came. So we moved as quickly as we could to be prepared. That's how we're functioning. A couple of meetings ago, we asked that you make our IV pumps surplus, and that at that time you had requested that we try to sell them for at least $1,000 apiece. We received a very, very nice gift of lab supplies from Cedarville that amazingly amounted to a couple $1,000, and we in exchange have given them a couple of IV pumps. So it worked out for both hospitals that we were able to give them the pumps that we had deemed surplus for about the same price as the lab supplies that had been sent to them by mistake, by the vendor. Perfectly good, we're able to use. Everybody came out good. Greenhouse project, or the Lakeview Gardens project. Several things are going on with that. We received our letter from Weinberg on Tuesday, and they said they would like now to have, we had sent in, we thought a full proposal, they said no, that's a letter of intent, now we're asking for the full proposal, which is virtually the same, but we'll give them their financial information, the same information that we've done before. So we have up until November to get that in, and then we'll know hopefully by January, February, and they would fund if we get the award in March, is the timeline that I brought you. So I'm very excited that we actually got our letter, like they had promised that we should have heard from them 8 months ago.
Are we jeopardized by starting the project?
No. Specifically asked that question and got a specific answer saying no, we would not be jeopardized by it, because that was one of our big concerns. We've asked in our initial letter of intent for $1.8 million to pay a portion of the construction cost of the Lakeview Gardens assisted living and the long-term care facilities, cottages. So that's what that money is going to be doing. So we're very pleased about that. Cheryl and I have been working the financing for, or refinancing for both the, with Washington Federal for the 2 series programs, if you recall, $13.3 million for the refinancing, and then the $5.5 million for the long-term care cottages. If we can get them to lock in the rates this week, that might be a very positive thing, but right now we're targeted to lock in on September 22nd. There is a fee to lock the rates. It's about $18, if I I recall, about $18,000 to lock it in for the 30 days. We'll see if we get it extended for 45, because there's still 26, that would be September 22. But given the rate that the market has gone this week alone, it would be very much in our benefit to secure a rate right now.
And I'm concerned the feds are gonna start to creep on us.
Maybe.
Maybe, there's always a maybe, but we're pretty good interest rates right now.
So the plan is that on September 22, we would lock the rates, if not sooner. And then we would sign the documents on October 21st, and they would fund on October 22nd. That is our target and our plan. We're moving toward that. Jim is helping advise us as we look over the documents. There's a bunch of approval processes, a lot of documents that we're working on in that process. Sorry, any questions about, well, on that?
And all the bid presenters on general contracting been notified of our choice?
They were notified immediately.
Okay.
That went out as part of the notice on the day the decision was made 2 weeks ago to choose, where you authorized me to negotiate with the joint. And so they were all notified of that. And the requirements were, if I was not able to secure rates that were acceptable, or the parameters that you defined for me, then we would go to the next contractor. And as you all know, we reached reasonable terms that we felt were acceptable. We were very close to the parameters that you had established for me to negotiate with, and you agreed to that. And you authorized me to enter into contract with them last Friday. Contracts have been reviewed by Jim. They are adroit. They advised me they should have that back no later than tomorrow midday. So we should be able to move on that. The plan then, of course, is that they would start immediately with pre-construction, and we'd be moving forward in that process. So I'd hoped I'd have the agreement to show you tonight, but I don't.
It is another reason to try to get our financing locked in.
And we're trying to do all of these simultaneously, so there's a lot going on, but we are trying to stay on top of it. I'm not able to get all the things done as fast as I want, but we'll move it. And Cheryl's, of course, got her moving herself physically, so we will be doing a review with the town, have material to them. We're working on getting that completed for next week, because we have to have town approval to
Planning.
Planning. And I believe, I don't know if you sit on that still, but we're moving forward on that. Certificate of need, as you know, we have to have certificate of need for us to relocate all of the beds. We were surveyed by Jane Fussell, is her name, who comes from the Office of Certificate of Need. She came out to look at our current facilities and find all the problems, and she was quite surprised when she learned that their average length of stay is 1.5 years in our facility. It is truly people's homes. So it was astounding for her to understand that moving from an institutional type environment, even though we try to do our best to make it a home-like environment, into a cottage really does make a difference. And the cottages, just so that you know, the literature is saying we are on the forefront of the way that all long-term care facilities are moving toward. So we're really on the forefront of that. Cheryl has prepared some of the necessary financial information. We are in the expedited review portion of the certificate of need. We can't even start construction until we have that. It looks like it'll be in October is what she said. We should be able to have the approval of the expedited approval, or approval from the expedited process of the certificate. So we feel like we're moving ahead on that. Our auditors will be here the week of October 5th. So as you know, Moss Adams comes is contracted to audit our books. They're doing that for the district, so the hospital, and home health and hospice agency. They're also contracted to do Lakeview Gardens, and we've added in the rural health clinic, so they're handling all of our components. They will be here the week of October 5th to do their audit as well as the preparations for the cost report. They do them essentially simultaneously. Some organizations have one firm doing the audit, one firm doing the cost report. We've agreed that it would be best to have one firm do both. So their goal is to have, we got the report last year, the end of December, if you recall, we had a special meeting. Their goal is to have it done in November. They don't see, Tony said today, that he didn't see any reason why we wouldn't be able to have that report, which would be a positive thing for us.
Does that include Goose Lake?
Yes.
Okay.
Now, it will not be an audit. That will be, no, excuse me, it will be an audit. It will not be a cost report. So the cost report will be for the hospital, for both Medicare and Medicaid. And the audit will be separately for the district and then the separate company. And that's because it's a 501c3 for Goose Lake, which includes the clinic as well as the long-term care facility.
And did we do a cost report for the rural health clinic?
Yes.
Okay.
Yes. It's a different time period. That's a calendar, I think it's a calendar year rather than the fiscal year, so it's a little bit different timing. But that will be part, and our clinics will be treated as part of a hospital. They won't be a separate component this last year. Because that didn't really, it has not become deemed as a rural health clinic. And we didn't have it until July 1st. As you heard, Bill Elrick is not, has declined to come and didn't give us specific answers, but he said he's having more trouble than, and we thought at one time it might have been his wife's health. But whatever it is, we're off looking at other applicants. Is there anything I can tell you that you have questions about?
The OBGYN.
We called and they had hoped they were going to have a interview in Texas, and that was supposed to have been in August. At the end of August, he said they were hoping to have it in September. And we are one of the options. But as you can imagine, in a physician that's actively practicing, getting away to getting on a call, making arrangements, it's difficult to do. So we have two other OBGYN interested applicants, and one would not have been available until November. We're actively working on that too. You know, just keep trying. It is constantly a difficult issue for any rural community to find physicians to come or they're in high demand everywhere. So we just got to keep working.
And you hired an IT manager.
The IT manager, Stephen Vance, all things, I mean, I hate to announce anything until they're physically, I see the whites of their eyes. But the goal is that he would be here on the 14th of September. I am fairly confident he will be here because we've been interviewing his wife to work in our operating room. So we're, I don't want to.
Where's he from, Charlie?
He's coming from Providence, and he and his whole family have lived in just outside the Portland area.
Oh, so he's an Oregon.
Not only is that, his wife's family is from Lakeview.
Kelly Sassman.
Really?
Okay.
Oh, really?
So
I'm very confident they're coming. They're buying a house.
we have a great deal of confidence,
They're
but you know,
buying a
I
house?
don't want to-
They are
Who is
buying
it?
a house.
Is it?
Kelly Sassman.
Yeah, I know Kelly Sassman.
You
She would.
I do.
So, we are, again, we have a lot of things going for our IT person to come right on, and we're gonna make sure they start running right away. There's a lot going on.
It is interesting though, isn't it, that Lakeview people want to come back in these positions?
He actually tried before, but we didn't have, we were just kind of in the beginning throes of developing our IT department. And we didn't offer a lot. And, but then he came back on this last one, and they wanted to come back to raise their kids here, so.
Yep.
Yes, that is the reason.
Good.
One of the things that we're going to have to, and Jane, you weren't here in these discussions, and I don't know, Gerald, you were, maybe you were. But, pardon me. When we talked about going to an electronic health record, there was a concern that we would start expanding the number of people like crazy. And unfortunately, lots and lots of hospitals, every time you add anything, the place that you add people faster and faster is in the world of IT. And we've tried to be as judicious as we can to not add lots and lots of people. One of the things that, as the processes have become more and more sophisticated, what you end up having is essentially two different fields. One is the management of the hardware, the main software operating systems, and that's the information technology. Then you have another group that is made up of nurses, pharmacists, therapists, sometimes doctors that are involved in what's called informatics. And that is actually where you take the information that you're trying to gather and try to see if it makes sense to a doctor, makes sense to a nurse. Does it give you the kind of reports that you really want to? And we've tried to find a nurse that can do the systems. That doesn't work very well. We try to find people that understand computers and see if they understand the processes that nursing and doctors understand and its struggles. So, for example, in Providence, now granted, they're a very, very big organization. And as Stephen said, they have 7,000 PCs that they maintain. But they have a whole team of informatics people just to help make sure that the systems work for the practitioners. And at some point in time, we may have to start bringing on more informatics people. Because you just don't find people with those skills that have both. And it's harder and harder to do as the stuff gets more sophisticated.
And you're still looking for a clinics manager.
We are. We've had some good candidates. Not everybody wants to come to the real work. So we just keep looking and keep working at it. So far, by and large, the physicians have been willing to accept the fact that we keep looking. We want to find the right person. We have, I think they have expressed a lot of support. Certainly, our doctors here in town have a lot of support for both Lisa Pike and for Chelsea Chartier. They've done really well. The staffs have been very supportive. It's not easy to do, but the doctors have been pleased with this. It's not a long-term solution. They understand it, and they're willing to give us a chance so far. But I don't think it's going to be a long time. I mean, if we don't get something done quick, the situation, this is not something we just let not happen. So,
Any other questions?
Ship director, position filled?
we interviewed a person today on Skype, and so we will we have gotten several applicants. Some have not understood what a ship person is responsible to do, so we've had some goofy applicants. But we've gotten some good applicants, and certainly the one that we interviewed today has some very good capabilities. So hopefully within the next 10 days, we should be able to have some interviews, get somebody hired. It has made, I think, a big difference in especially as hospitals begin to focus more and more on population health. We are right at the forefront of where things are changing. So everybody else is jumping on the bandwagon, if you will, of working on public health. And we're right there. That's a positive thing for us. So.
Linda, do you have anything you want to add?
And Charlie, Dr. Quinn is here.
Dr. Quinn has been here. He got here it was a little bit later than he anticipated, and that was largely because of getting his Oregon license. His original plan was he would be 3 weeks on, 3 weeks off. Because he didn't get his license, he got a little bit of, his schedule got a little bit kittywampus, so he's going to be doing 2 weeks, and then he's going to have a little adjustment of time. But he thinks by the end of the year, he'll be able to have a consistent plan. And Dr. Bradbury has also been able to be here now much more consistent. But, you know, hunting has caused a little bit of adjustments in schedules. But yes, he is here, and we've been very pleased with, and he, as an addition, as a physician here.
Good.
Did you have anything else to add?
The only thing is, I'll tell you that we are struggling in the nursing area because we're experiencing a lot of people transitioning, moving. Plus, around the state and all over the US, all the older nurses are now, if the market doesn't go berserk on us like it is, they're gonna retire. So I feel we're fortunate because we do have 3 LPNs moving into the nursing, which I know 2 will for sure remain here, come back. That's a very positive for us, because the ones that are here are many nurses that were educated through Patricia Green Johnson Fund and raised here, want to be here. They'll raise your kids here.
Yeah.
So, but it's a real issue for us right now. We do have travelers in, which we do not like to have, but we have to have. So it costs us and it's not ideal, but that's our big challenge right now.
Have we got a CNA training program yet?
Very close. Melinda got back from the State Board of Nursing. She submitted her application where the first part of it, the instruction part, is a computer learning process, which is the only one accepted by the state of Oregon. And then the clinical is done here by one of our nurses who recently broke her leg. We have some of those issues too. I mean, we've had other things other than people moving some medical leaves that are affecting us. But they requested a couple more things, and we could have it approved soon, so we're hoping to start in October. And that will be huge, because for the first time in probably, I would say 15 years, we've had to get travel CNAs. They're very hard to find, because they're usually local, and to find them, they have to have an Oregon certification. But we've got one on Teresa's side, and we got one today, we think, for Melinda's side, but we haven't had that. And used to be you could go kind of to some agencies, local, out of Bend, out of Clam, those don't exist anymore.
So when she gets this done, we'll be back to where we were
Yes.
during the swing vote?
She'll do one in October, and then we'll probably do another one in potentially December, at the very latest January. We'll do them probably every quarter, because between acute side and long-term care, we're in desperate need to have depth of CNAs.
Can you train them that quickly?
Yes, it's a process. They have 75 hours of classroom instruction and 75 or 80, they just change it, of clinical. And it takes about 6 weeks to 2 months to get them where they're able to test with the state board and pass their boards. It prepares them to test. And that is done, Mary Anderson can do the testing here. She's qualified and assigned to do that, or they can go out in the state, but that has been a huge detriment, not being able to produce our own CNAs.
I can tell you that is a big issue in our JPA conversations about how can we work together. Because everybody has struggles with getting good staff. And being a CNA is not an easy position, it's hard work, and it is not a highly paid position. So it's an entry-level position for a lot of people.
But that's about it. Nursing and CNAs are an issue currently.
One of the things that we may be coming to you in the not too distant future is thinking about maybe we need to reconsider some of our incentives to keep people here longer. And to keep people to stay 3, 5, 7 years. Economic incentives. Because we are seeing so many people, as the economy gets better, taking jobs elsewhere. And it's expensive, it's difficult, it's traumatizing to those that are here because they have to retrain somebody. So we're working on some suggestions.
Okay, thank you. Brian, do you have anything you want to add?
Well, it's been an eventful summer with changing ownership of long-term care, acquisition of the clinics, eClinical, going live with eClinical. So it's been a lot of good changes the past couple months.
Feel all smooth there,
It's starting to. It all came at us at once.
yeah. We'll wait and see it in the AR.
Yeah.